Good morning, everyone. I'm Dr. Ujjayini. I'm here to talk about ARDS and its management. So, what is ARDS? It is nothing but acute respiratory distress syndrome. So, it was defined as a syndrome of inflammation and increased permeability, which led to bilateral infiltrates, which was of acute onset, and chest radiographic features with bilateral infiltrates, and PF ratio, which is nothing but partial oxygenation of arterial blood were is to a fractional inspiration oxygen, which is less than or equal to 200. That cannot be explained by left heart dysfunction. In term, how do you explain left heart dysfunction? Either by pulmonary artery wedge pressure, which is less than 18 millimeters of mercury. So this was called as AECC definition. But we then shifted to something called Berlin's criteria. So this was brought up by adding P, that is positive end expiratory pressure, to the already existing criteria. So according to Berlin's definition, we added timing of ARDS, which means acute. We call it as acute respiratory distress syndrome. Acute means we have to give some timing for it. So we added the timing. Next, we came to a conclusion that a chest imaging should contain the following criteria to call it as an ARDS, like bilateral opacities, not fully explained by any other coexisting effusions, low bar, or lung collapses or nodules. And then we also added some criteria to rule out cardiac failure features, which do not contribute to cardiogenic pulmonary edema, because ARDS is a non-cardiogenic pulmonary edema. So origin of edema not fully explained by cardiac failure or excessive intravascular fluid volume. And fourth criteria was regarding oxygenation impairment. And that's where we gave more importance to PF ratio. Along with that, we added PEEP, or continuous positive airway pressure of 5 centimeters minimum or higher, which can be given by non-invasive route or invasive route. And anything PF ratio less than 300 was considered as ARDS. So we then classified it further into three stages. ARDS is mild, moderate, and severe based on PF ratio. So PF ratio is between 200 to 300. It was called as mild. And between 200 to 100 it is called as moderate, and less than 100 is called as severe ARDS. So what are the causes for ARDS? We classify it as pulmonary and extrapulmonary causes. Pulmonary causes can be otherwise called as primary causes. So primary causes could be anything that is related to a lung. Anything that disrupts the architecture of lung, or anything that originates from the lung. We call it as primary or pulmonary triggers. It includes pneumonia, aspiration pneumonitis, lung contusions, smoke inhalations, oxygen toxicity to the lungs. If the patient is on mechanical ventilator with 100% FI2 for a prolonged period, pulmonary embolism, radiation to the lungs for any type of carcinomas, drugs that are like bleomycin, which can cause fibrosis of the lungs, or near drowning. These all contribute to pulmonary causes. Coming to extrapulmonary causes, sepsis is the most common. Sepsis is the most common among all causes of ARDS and also among extrapulmonary causes. So sepsis is the first one to cause, then followed by trauma. Polytrauma patients, because of inflammatory mediators and inflammatory cytokines, can lead to ARDS. Shock, especially septic shock, followed by burns, because we give excessive fluids for resuscitation, that might cause ARDS. Acute pancreatitis. Again, in pancreatitis, there will be third space losing. Again, we are going to resuscitate the patient. There will be cytokine involvement, SARS, that is systemic inflammatory syndrome. So again, that might cause ARDS. DIC can cause transfusion reactions like TRALI. They mimic ARDS. They can also cause ARDS. Neurogenic shocks can cause pregnancy-related causes like amniotic fluid embolism can mimic ARDS. It can also trigger it, and anaphylaxis or anaphylactic shock. Now coming to pathogenesis. So ARDS is an inflammatory lung lesions, because there is involvement of so much of pro-inflammatory cytokines. The balance between pro-inflammatory and anti-inflammatory cytokines is getting disrupted. It is triggered by multitude of insults, like between the host immunologic mechanism and the triggers which cause it. So sepsis, especially pneumonia, is the most common cause among pulmonary and extrapulmonary, as we already saw. And the other causes like major trauma, burns, electrical injuries, drowning, toxins, charling, these can also cause ARDS. So in the classic model, we had something called a classic model. where an inflammatory trigger causes recruitment of neutrophils into the capillary membrane, which led to addition of these molecules onto the surface. Once these neutrophils get attached, they start degranulating, and thereby they cause direct injury to the capillary membrane. Another reason is this: once the capillary membrane is disrupted, it increases the microvascular permeability. Once the permeability is increased, automatically water, salt, macromolecules, everything start entering into the interstitium and thereby cause pulmonary edema. So another mechanism is apoptosis of type 2 pneumocytes. So type 2 pneumocytes is something involved in protection of lungs and they by producing surfactant. So this ARDS causes apoptosis of type 2 pneumocytes. So there is no surfactant available for preventing atelective trauma. So this surfactant depletion causes atelectasis, which results in loss of P and collapse of lungs, especially posterior portion of the lung when the patient is in supine. That's why we have something called proning position. So we will discuss about it later. So the most common involved part is posterior part in a supine patient. So we already saw it is an acute respiratory distress syndrome. So let's classify it into number based on the period of onset. So during the first week, that is during first 7 days, what is going to happen in an ARDS? It is called as exudative phase. So during this exudative phase, there will be capillary leak, inflammatory eruption, atelectasis, and acute cellular inflammations. So these things go on during exudative phase. If we find out the cause for this, and if we address the cause, if we treat the cause, and if we prevent it from further damage, patients mostly heal. Next, going to the next 7 to 10 days. Here, this inflammation is going to stop. And this acute inflammation will stop. And further, it will go to the next stage of chronic inflammation. So, chronic inflammation includes fibroblasts. This will start try to heal by producing collagen. So, it is called as fibroproliferative phase. Okay, so coming to clinical features. First feature is going to be the time of onset. It should be of acute onset. Acute onset means it should be within less than 1 week. Sudden appearance of hypoxemia, the blood saturation of oxygen should be low. PaO2 should come down. And there should be signs of respiratory distress, like the respiratory rate should be high, as in case of tachypnea, or the patient should have difficulty in breathing. Taking radiological evidence of chest X-ray, there should be bilateral pulmonary infiltrates, which should not be explained by other causes like pulmonary effusion, nodules, or any kind of pneumonia, consolidation. So those things should be ruled out, which should happen within 24 hours. And respiratory alkalosis might be present, and the patient should go for respiratory failure. Now, coming to histological findings, we can see that neutrophil is the main cell of interest here. So there will be dense infiltration of leukocytes and proteinaceous materials get collected into the lungs. So this is the normal histology of lung. So when you compare with that, the volume has reduced in the pathologic lung. So in the normal lung, the alveolar volume is very high. Septal lining is very thin and there is no congestion. Whereas when you come to the pathological lung, all these spaces have been obliterated. There is no enough volume for the lungs to expand. The alveolar spaces have reduced a lot. So this is what happens. So what are the investigations we are going to send out? Since it is it can lead to multi-organ dysfunction. We have to get a routine CBC done, RFT to know whether the patient has gone for any acute kidney injury. And we have to get a chest X-ray done, ABG to rule out to check PF ratio. If possible, we can get a CT chest done, but it is not necessarily, it is not mandatory. If you have a chest X-ray, that is well and good. 2D echo, ball sample you can take when you suspect any infectious cause of lung. When PCWP, that is pulmonary capillary wedge pressure, you can take to rule out cardiogenic cause, but 2D echo is more than enough. So this is the difference between cardiogenic shock and non-cardiogenic shock, otherwise called as ARDS. So as you see in cardiogenic shock, look at the base of the chest X-ray. It contains bilateral pulmonary infiltrates. So this is what you call as Kerley V lines. Because of the septal thickening, you can see that the water gets accumulated in between the septa and those septa gets thickened and you can very well identify it. Whereas when you see the ARDS and non-cardiogenic shock, there are patchy infiltrates. you cannot say that the septal wall thickening is not that obvious, but you can say that it is thickened, it is bilateral patch, and it is infiltrates and it is homogeneous distribution. That is more important. It is not heterogeneous, it is homogeneous distribution. So same way in CT scanning, there is no septal thickening in ARDS. Instead, there is going to be direct parenchymal infiltrates. And here, one more thing, you have to see the dorsal aspect where the atelectasis happens most. So, different part is the part where atelectasis is more common. Now, bronchoalveolar lavage, we are not getting it done routinely in ARDs, but if at all you have to do bronchoalveolar lavage, present day it is for ruling out any infectious cause like VAP, ventilator associated pneumonia. Otherwise, we are not into bronchoalveolar lavage much. Now coming to management part of ARDs. First, we have to find the cause and correct it. So we have to find out the trigger. We saw about the pulmonary, extrapulmonary triggers. So we have to find out the cause and we can reverse the process once when the patient is within 7 days during that exudative phase. So that is one thing. Then coming to the duration magnitude of the initial insult. So that is directly proportional to the outcome and the severity of the ARDs, especially when it is going to be sepsis is the cause. We have to go on with sepsis surveillance, sepsis campaign guidelines, and we have to remove the eradicate the infections, which is the causative organism, or we can also go for some source control to remove the septic foci that can resolve the ARDS if you are not able to control the antibiotics alone. Next, while giving ARDS management, we should avoid something called barotrauma because already the alveolar space is much occupied. There is no enough volume for the alveoli to expand. So if we keep on giving much more pressure from outside by positive pressure by using positive pressure ventilation, that may lead to barotrauma, and that can further lead to biotrauma, something called biotrauma. So we should avoid that. And one more thing is we should avoid normal or high tidal volumes. There was a trial which was called as ARMA trial. They compared tidal volumes, high tidal volumes versus low tidal volume ventilation. So in high tidal volume ventilation group, they provided with 10 to 12 ml per idle body weight of tidal volume to one group of patients, and the other group they gave 6 to 8 ml per kg idle body weight for the next group, which was called as lung protective group. So the mortality was very much reduced in the lung protective group. So as per this trial, low tidal volume strategy is what we follow to prevent ventilator-induced lung injury and barotrauma. And coming to mechanical ventilation per se. So there is a difference. We have to find out the difference between cardiogenic and non-cardiogenic. So why are we finding the difference between the cardiogenic and non-cardiogenic is in cardiogenic pulmonary edema, the problem is with the heart. The heart is not able to pump out the contents properly, either because of reduced preload or reduced or increased afterload, or the contractility is not good. So because our heart rate is not that good. So the problem relies with the heart. So we either go with diuretics, nitrates, or NIV, non-invasive ventilation, to treat those treat cardiogenic pulmonary edema. So that will lead to improved left heart function. Whereas in non-cardiogenic pulmonary edema, the problem is not with the heart, rather it is because of systemic problems like systemic diseases, like as we saw trauma, sepsis, burns, or acute pancreatitis. So it is the line of management changes entirely. It is entirely different from cardiogenic pulmonary edema, and mechanical ventilation plays a very important role in ARDS management. So as we saw, the exudative phase in the first 7 days is a point where we identify the cause and treat it quickly so that it is reversible. So, how are we going to treat that? So, what is the indications? What are the indications for mechanical ventilation? That is what we have to see first. The patients, we are getting an ABG done, as we saw in the investigation part. So, we are going to calculate the PF ratio. If PaO2, individually, if PaO2 is less than 60 millimeters of mercury, with adequate FiO2, that is, if we are providing 60% FiO2, despite the patient's PaO2 is less than 60, then we label it as inadequate oxygenation. Then the patient might need drainage mechanical ventilation. Or the PaCO2 has raised to more than 50 millimeters of mercury. Here, the thing is, COPD patients will have a baseline of high PaCO2. We should be able to differentiate both. So from baseline, the other method is if the PaCO2 rises by 2 or 20 millimeters of mercury from the baseline, then you can take it as a criteria for starting mechanical ventilation. And also clinical signs of incipient respiratory failure, like the patient is in tachypnea, the patient is having sweating, patient is diaphoretic, he is using his accessory muscles to breathe. Those are the indications for mechanical ventilation. Now coming to one more pathogenesis of ARDS, there is something called the baby lung concept. So reduced functional volume. What happens is the ARDS is not going to affect the entire lung in a homogeneous way. Even though the infiltrates are homogeneous, it is not going to cause inflammation to all parts of the lung in an equal manner. So what is going to happen is one part of the lung will be affected severely and the other part is going to be affected mildly or not even affected. So those unaffected lung parts of lungs are called as baby lung. So your mode of ventilation, your mode of treatment should be able to protect those baby lungs. The aim is to protect the baby lungs from getting disrupted by ARDS. So that is where we start giving something called lung protective ventilation strategy by providing small tidal volumes. As I said, 6 to 8 ml per kg ideal body weight. So in some places, they can even go to 1 to 3 ml per kg ideal body weight. But you have to use some extracorporeal devices to remove the carbon dioxide which is produced in excess because of low tidal volume. And you have to provide PEEP to prevent atelectode trauma. So coming to protocol for lung protective ventilation. So first we are going to calculate the ideal body weight. So ideal is not predicted body weight, it should be ideal body weight. So it is why is it called ideal body weight? Because it depends on not only the weight of the patient, but also on height of the patient and gender of the patient. So this is the formula. So for males, it is 50 plus 2.3 times the height in inches minus 60. Whereas for females, it is just 45.5 plus 2.3 into height in inches minus 60. So initial tidal volume, as I said, there is a range. It is between 6 to 8 ml per kg ideal body weight. So we can start, let's consider that we start with 8 ml per kg body weight. Then we have to start adding PEEP. So positive end expiratory pressure, we add to keep the alveoli open. So physiological PEEP is going to be 5 centimeters of water. If at all the patient is in severe hypotension, then we can reconsider increasing the PEEP because PEEP is going to reduce the preload to the heart, which in turn will reduce the cardiac output. So it is based on the hemodynamic status of the patient. Why are we giving PEEP? Why are we giving more importance to PEEP? It also provides oxygenation, it improves the oxygenation of the patient. Because one of our main concern is the reduction of PaO2 and reduction of PF ratio. So by providing PEEP, we are going to increase the oxygenation. So there were some trials conducted like love trial, alveoli trial, which emphasized the necessity of PEEP by increasing the oxygenation. And then coming to lowest FaO2 possible. So there is something called ARDS criteria where you can provide FaO2 based on the FaO2, you can provide the amount of PEEP. So they compare the PEEP and FaO2 for 60% FaO2, how much PEEP you can give. So based on ARDS protocol, you can provide that. So the minimum possible SpO2 we would like to achieve is 80 to 95%. Need not be 100% SpO2. If it is somewhere between 88 to 95%, that is more than enough. Once the patient's saturation has improved by providing this low tidal volume, PEEP and FiO2, once the patient's saturation is improving, his hemodynamics is improving, then we will start reducing the tidal volume by 1 ml per kg from 8 ml per kg. So initially we kept it at 8 ml per kg. So we will start by reducing by 1 ml per kg every 2 hours until the tidal volume reaches by 6 ml per kg. So first stage is over. So we have reduced the tidal volume to 6 ml per kg from 8 ml per kg. So from the second stage, we are going to give importance to plateau pressure because plateau pressure is nothing but something recording to intra-alveolar pressure. So once the tidal volume has been achieved, now measure the plateau pressure. Our aim is to reduce the plateau pressure and keep it less than 30 centimeters of water. If at all it is more than 30 centimeters of water, we will further decrease the tidal volume to 1 ml per kg. Till the plateau pressure is less than 30 centimeters of water. And the minimum range to which you can reduce the tidal volume is 4 ml per kg. So till 4 ml per kg, you can keep reducing so that the plateau pressure becomes less than 30 centimeters of water. Then we go to the third stage. Third stage, we are going to get an ABG done to see for respiratory acidosis because the tidal volume is low. So there is a possibility for PaCO2 to build up. So we are seeing the pH. It is somewhere between 7.15 to 7.30. So it is in acidotic phase. Most probably it will be respiratory acidosis. So we will increase the respiratory rate to wash out the carbon dioxide. So we will increase the respiratory rate up to 35 breaths per minute. That's maximum range you can increase. That the pH becomes more than the 7.30. If at all the pH is less than 7.15, and we are going to increase the respiratory rate to 35. Despite increasing the respiratory rate to 35 and the pH is less than 7.15, you can increase the tidal volume by 1 ml per kg because PaCO2 is high because of this low tidal volume ventilation. So to counteract that, you can increase the tidal volume by 1 ml per kg until pH is more than 7.15 because it is more acidotic. 7.15 is severe acidosis. So in order to raise it, you can compromise on by increasing the tidal volume. So finally, optimal goals is tidal volume should be 6 ml per kg according to first stage, and P plateau, that is plateau pressure should be less than or equal to 30 centimeters of water with the saturation of 88 to 95% according to second stage, and pH should be somewhere between 7.30 to 7.45. That is your physiological pH according to third stage. Now, how to adjust the tidal volume and plateau pressure? So, titrating tidal volume to plateau pressure less than 30 centimeters of water. Preferably, it should be somewhere between 25 to 30 centimeters of water. So, if at all the patient is very obese, extreme obesity, and those obese patients will require more of PEEP compared to non-obese patients because their functional residual capacity will be low. So, extreme PEEP requirements like more than 15 centimeters of water will be required. In such cases, high plateau pressures are acceptable. So, how much high? Up to 35 centimeters of water, or just minimally about 35 centimeters of water is acceptable. So we have some exceptions. So not for everyone. You have to place a goal of reducing the P plateau to 30 centimeters of water. So we have exceptions like extremely obese patients and sometimes pregnant patients also because their abdominal pressure is high and the FRC is reduced. So the achievement of P plateau less than 30 centimeters of water is very difficult. So we can permit up to 35 centimeters of water. If the hypoxemia persists despite you are giving FiO2 of 100% and P for 5 centimeters of water, but despite giving all such measures, the patient is having hypoxemia, that is saturation is less than 18%, 90 is acceptable, less than 18%. Then to improve the oxygenation, you can increase the PEEP by 2 to 3 centimeters of water, or you can increase it straight away to 12 to 15 centimeters of water if ARDS is your primary diagnosis. Then by increasing for every 3 to 5 minutes, you keep on increasing it by 2 to 3 centimeters of water. Once the oxygenation pickups, then first by the weaning method is to bring down the FiO2 because fraction inspiration of oxygen, if it is too high, if it is above 60% for a prolonged period of time, that can result in oxygen toxicity and aggravate ARDS. So once oxygenation is achieved with 100% FiO2 and a good peak, first start reducing the FiO2. Once it is titrated down to 60% and the saturation is maintaining up to 90%, then we can go on with other weaning methods. So now the PEEP is increased. Once the PEEP is increased, you can now start reducing the tidal volume. And P plateau, the goal is less than 30 centimeters of water. So there is something called recruitment maneuver, and PEEP is one among the recruitment maneuvers. Okay, so coming to best PEEP, we don't know what measure of PEEP, whether it is 5 centimeters of water, 8 centimeters of water, 15 centimeters. We don't know the exact number of PEEP that gives a good oxygenation and a recruitment maneuver in a diseased lung. So that's why we formulated something called ARDS protocol. We will discuss about it later. Now coming to negative effects of PEEP. Even though we have so many studies supporting the effects of PEEP in recruiting the lung, improving the oxygenation, preventing intellectual trauma, thereby biotrauma, there are some adverse effects of PEEP. So we are going to concentrate on major two effects. So first is preload deficient patient. The patient is already in a shock, in a septic shock, wherein or patient is having a coexisting hypovolemic shock. Already the patient is not getting enough cardiac output to pump into other organs. Already perfusion pressure has been compromised. In such patients, if you're going to provide positive end expiratory pressure, it will increase the intrathoracic pressure furthermore, by thereby compressing the vessels which bring blood from the body to heart. So this leads to further depletion of preload and reduces the cardiac output by reducing the venous rhythm. This is the first major concern. Coming to second major concern is it is going to increase something called mean alveolar pressure. Because you're going to give pressure into the alveoli so that it doesn't collapse back. So when there is an increased pressure inside the alveoli, it is going to compress the capillaries surrounding it, and that may cause promotion of dead space. Because the capillaries is compressed, the exchange of gas will be inadequate, and that leads to dead space and further leads to shunting of blood to poorly ventilated regions. So these are the two major concerns. So which should be what are we more concerned about? So if increments of people, we have kept it up to 20 to 25 centimeters of water, and so that the FiO2 we can make up to less than 60 centimeters, 60%, then you can use it only for 2 to 3 minutes. So that is called as recruitment maneuver. The thing is, you can keep up to 18 centimeters of water, but if you intermittently raise the people to 20 to 25 centimeters of water, but only for a short period of time, transient period, like 2 to 3 centimeters, 3 minutes, that is more than enough, so that the oxygenation improves and you can reduce the FiO2 to less than 60%. Another option is allowing decrements of FiO2 by application of the food tank. For instance, if sepsis and other inflammatory process or control, if you have controlled the source, then the hypoxic pulmonary vasculature or pulmonary vasoconstriction, which is a protective mechanism, will improve the oxygenation. Thereby, the requirement of FiO2 will come down. Now, coming to a concept called permissive hypercapnia. So normally we used to maintain normocapnia, that is somewhere between 35 to 45 millimeter per mercury. That is what we used to maintain physiologically. But in case of ARDS, you can go into something called permissive hypercapnia, which means you can allow the buildup of carbon dioxide up to 60 millimeters of mercury. So what is the benefit? First thing is you are using low tidal volume ventilation, which will result in hypercapnia. By washing out of hypercapnia, then again you have to increase the tidal volume, which is going to harm the patient, and the lungs is going to get worse. So permissive hypercapnia of 60 to 70 millimeters of mercury, but simultaneously you have to watch the pH also. It should be somewhere between 7.2 to 7.25 is allowable. If it is going for severe acidosis, like it is going below 7.15, then you can increase the tidal volume to compromise the PaCO2 buildup. Now, especially this permissive hypercapnia is allowable in pregnant patients and severe extreme obese patients. Now, coming to recovery phase. So since mechanical ventilation plays a main role, we have to take care to prevent that is ventilator-induced lung injury by providing people low tidal volume ventilation and minimum FiO2 possible. Once the FiO2 requirement has reached 50%, then we can start coming down on people. These are all weaning processes. So first step is to reduce the FiO2 to prevent lung injury by causing oxygen toxicity. So once FiO2 reaches 50%, you start reducing P by 2 centimeters of water every 2 to 4 hours. So you have to reduce it gradually. Once you have reduced and P comes to the minimum level of 5 centimeters of water, then you have to concentrate on plateau pressure. So plateau pressure, you have to maintain below 30 centimeters of water for the given minimum tidal volume and minimum P for P for 5 centimeters water and tidal volume of 6 ml per kg or even less up to 4 ml per kg. The plateau pressure should be maintained less than 30 centimeters of water. So these are all the ventilator strategies we saw. Now coming to non-ventilator management. So what are the non-ventilator management is something called fluid management. So previously we had a study between conservative fluid therapy and giving fluid overload, like giving more of fluid to resuscitate the patient. But recently, conservative fluid strategy is what we follow because it has, even though it doesn't have mortality benefit, the lung injury has reduced. So next, coming to corticosteroid therapy, it has no very big role in resolving the ARDS, but rather we use corticosteroid therapy in ARDS only when to maintain the hemodynamic stability. If the patient's hemodynamics is not maintaining despite giving vasopressors, then as a last line, we can go with corticosteroid therapy. Otherwise, it has no role in lung protection or further progress of ARDS. In case of unresolved ARDS, you can give a trial of methylprednisolone, something called pulse dose therapy. That you can give as 2 mg per kg for over 30 minutes, then followed by an infusion for 14 days. And gradually we start tapering the dose, and after that we go for extubation weaning. Coming to refractory hypoxia. So if at all the patient is going despite giving mechanical ventilation, then you can add on some medications like inhaled nitric oxide, or you can go with VV ECMO if the lungs are alone involved, or VV ECMO if the cardiac part is also involved. Then you have something called prone position. Prone position is going to protect the baby lungs as we discussed earlier. And coming to high frequency oscillatory ventilation, we have a good trial on HFOB also, which improves the oxygenation for arterial oxygenation despite giving adequate PEEP. Inhaled nitric oxide is going to prevent their pulmonary hypertension and thereby reducing the dead space ventilation. But the adverse effect, it could lead to renal dysfunction and methemoglobinemia. Prone position, we have something called Florida trial, which has got mortality benefit. The maximum you can provide is 17 hours of prone ventilation, and something called extended prone, which can provide for up to 48 hours. ECMO is the last resort where the mechanical ventilation has completely failed, and you have you have to give some extra corporeal support for the lungs to function till it gets recovered, or it can be bridge therapy to lung transplant also. Coming to prognosis, mortality is somewhere between 25 to 44%. It can also lead up to 50%. So risk factors are mainly if a patient has a ARDS and the patient has coexisting multi-organ dysfunction like CKD, CLD, or if the patient is an age-old person, or even a very extremes of age, when it is of a very young age group, or if the patient is having some taking some steroids like chronic immunosuppression, patient is a known diabetic patient or any solid organ transplant patient, chronic alcohol abuse patients, then they are having a more of mortality than a normal age group or normal population. So since ARDS involves lungs and also multi-organ dysfunction, mechanical ventilation has to be the has got a main role to play apart from non-ventilatory strategies. Thank you.